how many of you are sick and tired of getting referrals from physicians? You just go, if I get another referral from a physician, I'm going to throw up. Anybody? Okay. All right, so a little bit of a rhetorical question there. I'm hoping that you're here to learn a little bit about getting referrals, getting respect from your sleep physicians in your area. When I say MDs, I don't want to say sleep physicians for the next hour. I'm going to say MDs, and just know that that means either sleep physicians or general practitioners, because I want you to be able to get referrals from all physicians, not just sleep physicians. In fact, I know several situations where some sleep dentist has put all their eggs into one basket, and then something happens to that referral source and their practice goes away. So you can't do that, and I'm going to be encouraging you through the next hour how to get these relationships with as many physicians as you can. If you did not know this, we are on an uphill journey, and I try to remind doctors about this consistently because I forget about this as well. Patients, the majority of patients that you treat are CPAP intolerant. Would you say that's fairly accurate? Yeah, okay. So if you've got a patient with wide goalposts, they adapt to everything, will they adapt to CPAP? Yeah. So we are getting patients with much smaller goalposts. It's more of a struggle for us than it is the first-line therapy doctors that are supplying CPAPs. So kind of always keep that in mind, and I don't know that that gives you any pleasure knowing that, but certainly it's something that we need to consider each time we treat a patient. Now, here are some reasons that MDs do not want to work with you, and I'm really going to tell you about the struggles we have first before I give you solutions. Because if you don't realize there is a problem or why there is a problem, then you won't understand the reasons for solutions. I had a sleep physician, my best referral source a few years ago was supplying me with patients, every mild patient that he diagnosed and every once in a while a moderate patient, plus his CPAP intolerance. With his decreasing reimbursements, he is now only sending me the CPAP intolerance or the PSG negative patients, those with no sleep apnea at all. So you're going to start seeing this because sleep physicians want to treat everybody now to make up for the income they were making years ago. I wish it wasn't the case, but it is. If you really think about this too from the sleep physician's perspective, they've gone 2 years in getting educated in their field. And if they know, and most of them think, that most of these dentists out there that come knocking on the doors and say, please refer me a patient, they know that they just went to a weekend course. And if you can consider yourself in their position, you'll understand that why would I trust somebody that just took a weekend course when I spent 2 years doing this? Will they take care of my patients? You don't know that. Lack of education in dental sleep medicine is big. And I'm going to show you some slides. We did some research with sleep physicians in 2015 to find out their thoughts and how they felt about treating or referring to dentists and what their knowledge base was on medical insurance covering dental appliances. And we'll go over those in a few minutes. They may already have a dentist they work with. You're not credentialed. Now, I know most of the time this doesn't matter to a physician. Honestly, I think the biggest reason for somebody not referring to you is that you charge their patients too much. And that's why it is so important to have this medical insurance thing figured out. If you don't, and your patient goes back to the sleep physician and said, he was going to charge me $3,500 in cash, that sleep physician will not refer you any more patients. Okay, so you have to figure the financial part out to minimize the out-of-cost cost to your patients. You're not in network. Now, I'm not suggesting any of you get in network. There are some pros and cons to this, but if you want to be in favor with your sleep physicians, you get in network. There will be some problems getting in network if there's already dentists in network in your area, so I'm not saying that's an easy thing. We got in network with Blue Cross many years ago, and we get paid $926.74. And that's less than Medicare. So I can't tell you getting in network is a good thing, but that's what sleep physicians want you to do. Correspond with your dentist, with your sleep physician. One of my referrals is only referring to me because the dentist he was referring to never corresponded with him, never told him how the patient was treated. I would hope most of you are at least letting your physicians know what is happening with their patient. Because if they don't hear back from you, they can't report to the MD that first referred the patient to them. That's their thought process, okay? So please correspond with them. Unfortunately, some physicians find out that we can make more money than the sleep physicians, and that's a deterrent to them sending patients to us. It shouldn't be, but it can be. They think you're diagnosing by doing HSAT. And when I sat on the committee that created the rule in Texas a few years ago, it created a firestorm, and the ASM came down on us and they wanted to sue us, and that was a few years ago. Nothing's happened, so I don't think anything is going to happen. But they do not like the fact that we use HSAT. They don't trust us. Now, do I use it? Yes. I have 22 units in my office and I use them all the time. But it is something that you don't necessarily want to broadcast to your physicians. And then just discomfort. Appliances, they think that they hurt, they cause bite changes, TMD issues. If you look at all of these reasons, it's tough. We got a tough row to hoe. So I want you to really work on this. This is something that you can do, but it does not happen overnight. You have to work hard at this, or you're not going to get very many referrals. We live in their world. It's the world of medicine, and we have to abide by what they want us to do because they're the bosses. I know we don't want to think that way, but that's the way they think. All right, so I want you to, this is a tricky slide. I want you to get on your phone and list reasons why you specifically don't get enough referrals from your MD. Come up with some reasons. I want to see what you come up with. Oh, come on now. All right, this is good. Okay, wow. A lot of reasons. I knew I could count on you. All right, now let me see if I can, I'm going to have to delete some of these because I'm going to have you vote on them, and I can't have you voting on too sexy. Wow, 47 reasons. Let's get to 50 and then we'll stop. Who's lazy, the dentist or the physician? Okay. Now, I think this is a little impractical. I don't think we can rank them because we have too many. And I didn't have time to delete them. The way this works, I'm supposed to delete all the duplicates and everything. This is a new system, by the way, that I've never used, so I'm glad you're allowing me to be you're the guinea pig, and I appreciate that. Okay, so we've got uneducated physicians out there. There's no question about this. I had a patient come in who was a pain patient, and I don't know if many of you work with a pain doctor that refers you patients, but this was a pain doctor that wasn't referring me patients, and he told the doctor that if his patient went to me to get an oral device, that he would withdraw his pain medicine from him. Yeah. You can't make this stuff up, right? Now, the HST and the Texas board, this is where this, well, they came down, and I don't know if you guys can read this, but I'm just going to, the last part is the most important part. The AASM recognizes the role that dentists can play in the provision of custom fabricated oral appliances for select patients with OSA. However, it is the AASM's position that it is outside the dental scope of practice for a dentist to order or interpret a study. They can't order a study. This is the AASM's protocol here. Certainly can't diagnose a patient. No, we don't. Can't prescribe treatment. No. So the AASM will continue to oppose the board's position, the Texas board's position. So they're opposing it, but I think they dropped the lawsuit. So I think we're okay. But again, sleep physicians do not want you to order HSTs. Now, here are some slides I'm going to show you that were results of the polling of sleep physicians. And this was a question about what makes you decide to refer to a dentist, right? When selecting a dentist to work with, 48% of physicians referred to several local dentists, but they are less inclined in 2015 than previous years to use DSM members compared to the other years. So I think that's fascinating. I don't know if it has anything to do necessarily with the ADSM, or if they are not looking at credentialing at this point as much, and they're more looking at cost for their patients, or perhaps locale. How close is the dentist to my practice? Next slide. What are your concerns, if any, when using an oral appliance to treat patients with OSA? Well, the number one was concerned about efficacy of treatment. I don't believe this. I really think that cost is number one, but I'll leave that alone. In the poll, this came back. I think they don't even want to mention cost. I think that's embarrassing for them to say. I don't know. But concerned about efficacy of treatment. So what do you do about that? I mean, we need to show our physicians that our appliances are efficacious. And we'll go through some detail about that as well. Patient discomfort is next, and then lack of insurance coverage. Would you believe that most physicians out there don't think insurance covers these things? And many of you may not know that. If you don't know that medical insurance covers these, they do. Concern about long-term effects, posterior open bite, things like that is next. So these are the concerns, and these are the kind of things that we need to alleviate on in the mind of our sleep physicians. So are they efficacious? Well, if you start treating patients, you can show them. First, you can show them the literature. There are plenty of literature out there, and if you need me to send you research showing that these devices are efficacious, let me know. I will send you anything you'd like. I've got reams of this stuff. There's plenty of information out there. Next, you have to show them proof. You have to show that you can treat their patient successfully. What is success in the mind of a sleep physician? Is it below 5? Is it symptom control? It's different with everyone. As an example, this is a WatchPat study, and we've got AHI. You probably can't read this. AHI went down from 42.7 to 0.7. If you treat enough patients, you're going to find plenty of positive results from these patients, okay? Here, well, sorry. Come on now. All right, so here's a 2003 PSG, 3 months post-insertion, and this was a follow-up with the PSG, and that's where you're going to win. If your patient goes back for a follow-up PSG and you get results like this, they will understand that patients are successful can be successful, even severe patients. Most sleep physicians think that these only work on mild patients. If we can convince them through treating their own patients. So let's say you've got a patient that comes in, you look at the sleep study, they were referred by they were referred by the internet or one of your patients. They weren't referred by the sleep physician. Once you treat the patient and titrate them by looking at HST, however your system is for following up a patient, whether you're looking at symptom control or whatever, I can tell you the best way to do it is with HST so that you can show numbers and then send the patient back. Once you've treated them, the sleep physician will understand that these appliances can be successful. I don't think that's news to anybody, but sending them back for a follow-up PSG is of vital importance, especially if you treated them. This was a patient that, this was the letter that I got from a sleep physician that said, wow, we could only get the AHI with CPAP down to, let's see, where is it? 16.6. But with the oral device, down to 2.8. So CPAP in this situation didn't work as well as oral appliances. It also can work on central sleep apnea. Now, many of you may not know this. There is some cross-pollination between central sleep apnea and obstructive sleep apnea. So I don't want you to look at a patient and say, well, you've got centrals, there's no way I can treat you. So there's several things that could be going on here. It could simply be that the centrals are causing some obstructions, the obstructions are causing some centrals, but it could also be the scoring that was used by the polysomnographer. And perhaps they just scored centrals a different way. So don't give up on our central patients either. And if you can get this patient to follow up with a PSG, it's going to teach our sleep physicians a whole lot more, because they certainly don't think that appliances work on central. Yes, sir?
I have a patient who had a PSG done. As soon as they put the CPAP on, the centrals increased dramatically.
Yeah, so if you didn't hear that, centrals increased after CPAP was put on, and that's called centrally mediated sleep apnea, complex sleep apnea, and it happens in about 20% of the cases. Most sleep physicians will then take the patient off of CPAP, saying that it doesn't work. They'll put them on some other kind of machine, VPAP, or they'll send them to me. I mean, in my area, they know that they don't think that appliances can create centrally mediated apnea, but we know that CPAP can. So the research isn't out there yet. I think there is always a chance that we can create centrals. I think there are some people out there that think that it can happen, but I haven't seen it myself. But following up with patients that have had centrally mediated apnea that have come about as from wearing CPAP is very important. Some physicians will leave them on CPAP for a month or two, saying, you know, at some point they'll figure this out and the centrals will go down. So what happened in your case?
I'm treating them with oral appliance and the centrals have gone down.
Good, good. Yeah. I love hearing those stories. Okay, this is important for you to know too, and I think it's important that we understand that if you have a CPAP non-compliant patient, an oral device is better than nothing. Now, some physicians won't agree to that. They'll say, you know what, it's a severe patient. I know that they're non-compliant with CPAP, but I'm not going to refer them for an oral appliance because they don't work, or they only treat mild. But if you can get somebody from severe to moderate, are they better? If you get them from moderate to mild, are they better? Yes. We know through the research you're not more likely to develop cardiovascular disease, any of the comorbidities, with mild apnea. Okay, I know that's tough for some of you to hear, but the research is not there showing that mild apneic patients are more likely to develop diabetes, any cardiovascular disease, cancer, any of these things. So if you have a patient that you've gotten from severe to mild, and if their symptoms are better, if they're feeling good, you have effectively treated that patient, and you can feel good about it. You do not have to get them below 5. Some people I know, you get them to an AHI of 9, and you go, well, I just can't fix you. The patient says, hey, I'm feeling great, doc. This is good. You know, please don't take this away from me. So understand this Kaplan research. It's very important. Yes, ma'am.
In the sleep lab I work at, about, I don't know how many years ago, it's been a long time, we had a sleep dentist approach us and usually they'll talk to me or my manager. And in my department, it's very small, we just want patients to, you know, we want to do something to help them so that they feel better. So what this dentist did is, I went in as a guinea pig because I've never heard of appliances before. He did the whole x-rays. I wore the tap. I loved it. Totally loved it. So there's only 2 sleep dentists. I don't know if they're accredited or anything that we use. The one that I went to, we had more. He moved. So, you know, for a sleep lab, if you can talk to their lead manager instead of going through the doctor, our doctor's really cool. We refer, you know, but it's hard to find somebody that knows going to do the right thing.
Okay, so she works in a sleep lab and she's struggling to find dentists to work with. So anyone want to volunteer to work to help? Yeah, believe me, I don't know where you are. I can help you out, I'm sure. I can find somebody. Where are you?
Kenosha, Wisconsin.
Okay.
In the middle of Milwaukee.
Anyone around Kenosha, Wisconsin here? Are you raising your hand with a question, or you're from Kenosha?
Oh, are you? Oh, wow.
We have a love connection. Yeah, so did you do a follow-up with the tap?
Yeah, and then I wore it out, so, and he was gone, so then I didn't know.
She can help you. She'll make you another one.
Yeah, I'll come see you.
All right.
Need your name, number.
All right, she's right up here. Now, you can't use an oral device to rob a bank. That's one of our benefits. You know, and if this is what it takes to convince a sleep physician to refer to you. However, did you know this research just came out? Journal of Clinical Sleep Medicine. How about this? Maybe some of you don't know what sexsomnia is. Sexsomnia is having sex when you're asleep. Okay? I don't know why it's a disease or a pathology. It makes no sense. Why do you want to cure that? I don't know. But we now know that oral devices can cure sexsomnia. I mean, who would have thunk? Okay, so let's talk about discomfort and long-term effects. How many of you make appliances on people and they complain about discomfort? Has it ever happened? Okay, yeah. So we know that it happens. How many people have heard you complain about CPAP discomfort? Okay. Do you think that they talk about these side effects with their patients before they give them a CPAP? Now, I'm going to give you the CPAP, but it could create lines on your face. It could create retrusion of the maxilla. It may leak on you. You may get bloated. Are you sure you want to wear a CPAP? Does that happen? No. No, no, no. But it's incumbent on us to talk about every side effect that can happen. All right? I've been doing this for 23 years. I've never been sued. I've never had, oh shoot. I've never had anyone get upset at me for a bite change. I mean, we talked about all this stuff ahead of time. And if you do that, if you cover the objection before the objection, you're going to be good. This is some research in sleep and breathing. It's now about 5 years old. But if you're not familiar with the research, they looked at patients over consecutive time periods. And what we see is that the TMD decreased over time from visit 3 to visit 4. It actually went down to 8.2%. So we do know that we do have some TMD discomfort with patients. However, we know that it's transient. It's not going to be there forever. And patients that have existing TMD problems, it will not exacerbate those symptoms by wearing the device. I know a lot of people will not treat somebody with TMD symptoms, but I'm telling you, it's not difficult to treat these patients. I would suggest that you be careful, but you can improve their apnea while not making their TMD symptoms worse. What is your concern with bite changes? "47 votes out of 72. All right, so it's fairly evenly distributed between these. That's very interesting. My guess is that those of you with more concern, say the 19% light blue over there, I think you probably haven't treated that many patients. I don't know who you are, but I know that the more you treat patients, the less likely you are to be concerned about these bite changes, because you understand that these patients with bite changes do not end up in pain. They don't stop wearing their device. I've had maybe 2 patients in 23 years that have stopped wearing their device because of bite change. Just doesn't happen, okay? I'm not 100%, but I think, well, you've heard this before, is what's more important, the way the teeth fit together or the next breath of the patient? I mean, if you think that the way the teeth fit together is more important than breathing, then this isn't the field for you. You need to be going somewhere else. This is, sleep medicine is not where you should be. And I'm sorry that's sort of blunt, but you're going to get bite changes if you treat very many patients. How many of you had seen bite changes? Yeah. Okay, those of you not treating, you saw the hands. Yes, sir.
Isn't it just a transient change you're looking at anyway? By the time you're out there applying it, it's back into the normal vision, or you see some change?
Yeah, the research is pretty clear on this, and anecdotally we can all tell you that if somebody stops wearing a device in, say, the first 3 or 4 months, unless they've recovered a disc, if they stop wearing it in 3 or 4 months, the bite will go back. But much longer than that, and it's not a transient change, it's a permanent change. So that's what we have to tell patients. If you do not like the changes in your bite, if you want to go back to how you were snoring and not sleeping with your husband, and because of the bite change, then you have to let us know in the first 2, 3, 4 months, because if you wait 2 years to tell me that, it's going to be too late. So yeah, it's unfortunately, for those of you that are that concerned, I'm actually kind of excited when my assistant tells me that someone's got a bite change. I know that seems weird to you guys, but I think that they're breathing better after the bite change. All day long, they're breathing better, right? Question? No, okay. Posterior open bite. They found it, see, I'm glad you asked the question, because here's the research on it. Even though we see bite changes, and they get more common the longer the patient wears it, we used to think that about 45% of bite change occurred in year 1, and about another 40% in year 2, and then just very little after that. But I can show you many of my patients that continue to have bite changes 5, 10, 15 years out. It can continue to happen. We don't know when it's going to stop. But only 28.6% of these patients even know they've had a bite change. Okay, so I want to alleviate those concerns from you guys. Most patients don't even know when it's happened. You think you would know, right? You think all of your patients would know, but that's not the case. Another poll of the sleep physicians. Under what circumstances do you refer OSA patients for oral appliance? So if the patient previously failed CPAP, that's the most common reason. Or if they request oral appliances, if the patient has mild, if a dentist referred the patient to me, if the patient has moderate OSA, see how low that is? And it went down in 2015. They're less likely to refer moderate patients in 2015 than 2014. That should be going up. We should be showing our physicians that these work in moderate and severe patients, but it's not going up. Do you have follow-up visits with OSA patients after they are fitted with an oral appliance? Okay, were you aware that your sleep physicians contact their patients and want them to come back? And if you don't provide good therapy, if your patients give a bad report to the sleep physician, you're in trouble. So you need to treat them correctly, treat them successfully. I have physicians that the day they send the patient to me, they also make an appointment 3 months out for that patient to see them. They want me to fix that patient in 3 months. That's a little tough for some patients, as you know. But they want to see those patients back, and they are contacting those patients to have them come back. I want you to be aware of that. In your experience, which of the following best describes insurance coverage? Now, this is ridiculous, I think. Medicare and a few commercial, about half of them think that. Medicare and most commercial, only about 1 out of 5. No insurance covers it, only Medicare covers it, and then a lot that aren't sure. So maybe what you need to concentrate on is letting your physicians know that insurance covers it. Insurance has been covering this for 10 years. Why do they not know this? You need to educate your physicians. Now, this is what their take is on HST, and I can pretty much tell you, you can take this to the bank. This is what they think of HST. They think it's a blunt tool. It's not as accurate as PSG. I've got sleep physicians that will not send a Medicare patient home with HST, even though Medicare would cover it. Even though the patient begs them, they will not send them home with HST. They think it should only be used with a high test probability. If it's negative, they want them then to follow up with a PSG, which I guess I can't argue with. Some HSTs are better at recording sleep time, real sleep time, than others. Some just record the time the monitor's on. So I would look at that when you're trying to decide what kind of monitor you're going to use. Some think it's not good for patients with comorbidities. So we're behind the 8 ball with HSTs with most of these physicians. Okay, I want you to list some HSAT units that you have. I want to see what everyone has in here. Even though we're not supposed to own them, I'm curious what you guys have. Shame on all of you for having all these units. We're not supposed to. Wow. Nice variety here. Okay, I don't know what a Weinmann is. Someone's going to have to tell me what that one is. All right, let's move on. So how do we get the MDs to respect us? Okay, so I've already been giving you some hints. First, you've got to treat the patient successfully. You've got to follow them up. Follow your patients up, follow your patients up, follow your patients up, and then return them to the MD. If a sleep physician sends a patient to me, I am not using HSAT even for titration. The more HSAT is used in the sleep world, the more likely that patient, when I send that patient back to the sleep physician, they're very likely getting an HSAT from the sleep physician. If I just gave them an apnea link air and they go to the sleep physician and the sleep physician gives them an apnea link air, the patient's going to say, why am I doing this same study again? Dr. Smith just did this same study on me. So what we do when we get referrals from sleep physicians, we follow them up with pulse oximetry. We only use that so that when we're then ready to send them back to the sleep physician, we say, you know, you can request a home sleep test that's much more robust than this pulse oximetry we're using. We don't want to upset the sleep physicians. So I would suggest that you try that. especially with referrals from sleep physicians. Follow up, follow up, follow up. Okay, then you've got to upskill yourself in the field of dental sleep medicine. I think you're here. It's a good thing that you're here. I think you should go to as many meetings and events and lectures as possible. The more you can learn, the better off you're going to be. Your sleep physicians will appreciate you for that. So let's upskill ourselves here. Case presentation. We have a 25-year-old male, symptoms of loud snoring and an Epworth of 15. AHI is 2.4, lowest saturation is 89%. Does he have sleep apnea? Is he a candidate for an oral appliance? Answer, does he have sleep apnea? We're getting a little disagreement here. All right, there's 50 answers. Now, is he a good candidate for an oral appliance? We have a saying that oral appliances work 100% of the time. And you got to go in with that attitude. All right, there's 50 responses. That's the answer. Not enough data. Okay? We could say yes, he has it, but we missed it because REM was not achieved in the study. He woke up 2 hours early. Supine posture, he slept on his side the whole time. Sleep efficiency was 30%. He had an HST, that was what the study was, and we looked at full sleep time, or full recording time instead of sleep time. RDI was 45, and you rescored at 3% instead of 4%. That will change his sleep apnea to 2.4, 20 sometimes. I mean, when you change the ruling, and you can change that on most HST units. More and more insurance companies, by the way, are requesting a 4% rule be used, though. And we're getting denials from UHC and a few others by using the 4% rule, the 3% rule. So if you can set your units to 4%, I would suggest you do it just to remove any denials from insurance companies. It's something that we've recently started doing. They didn't used to do it, but they're doing it now. Just something to keep in mind. No, he doesn't have sleep apnea because we looked at all positions, all stages were seen, but he's still sleepy. So what do you do with this patient? You know, is it sleep deprivation medications? There's other reasons for fatigue and sleepiness. Fatigue and sleepiness is not a predictor for sleep apnea. It's just not, because there's many reasons for fatigue and sleepiness. You have to get to the bottom of that. Okay, second case presentation. 45-year-old female. AHI 5.2, REM AHI 15, nadir is 80%, sleep efficiency 87%. We saw all stages and all positions. Is this patient a good candidate for an oral appliance? Not enough data. Sorry. He could, well, not sure. Not sure is that option. The patient had 25 minutes with saturation persistently below 85%. You don't know. I personally think the nadir is worthless. I hate that number. It tells me basically nothing. And most PSG reports come back with a nadir and they don't tell anything about T90, the percent of time under 90%. So that data means much more to me than the nadir. AHI could have been all centrals. I mean, central sleep apnea should be tried with CPAP first. If they do not wear CPAP, can't wear it, not effective, increases the central apneic events, it's time to move to an oral device, but they should be tried. It could be on pain medicine. Okay, final case presentation. 49-year-old male with daytime somnolence. That means they're sleepy. Loud snoring and fatigue. Neck circumference is 17. That's right on the verge there. BMI 42. He's a little overweight. AHI is 2. REM AHI 4. RDI 8. Lowest saturation is 89%. Wow. You don't see this very often. All positions were noted. 90% sleep efficiency. Does he have sleep apnea? Yeah, that not sure keeps growing. All right, we're up to 50 responses. He does. Little did you know the technician put oxygen on him at the beginning of the night because the patient said, I always sleep with oxygen. Yeah. Lack of desaturations caused no hypopneas to be scored because you have to have a desat to score hypopnea, which lowered the AHI. So, all right, trick questions, but all I'm saying is you have to be aware of all kinds of things when you're looking at sleep studies, and you cannot make assumptions that are incorrect. You need to upskill your education in sleep so you know what things to look for and what questions to ask. All right, let's look at some other strategies. Refer. Refer, refer, refer. You need to have a sleep team that you're working with. You need to have a psychologist, an ENT, sleep physicians obviously. You need to have a referral system because the more you refer, the more likely you are to get referrals back. Your patients have sleep problems. 4% sleepwalk, 2% have sleep tears, 10% restless legs. Some have sleep-related breathing disorders, some have sleep-related violence, that's REM behavior disorder. So this is about 15% of your patients, and that's before you even talk about insomnia and sleep apnea. Your patients have sleep problems. You have many areas where you can send patients to your sleep physicians. Ask every patient about their sleep problems and refer, refer, refer. Okay, offer a variety of appliances. No sleep physician wants you to only make one appliance. They don't make one CPAP. They don't use only one mask. They know patients are not treated with the same therapy. The ADSM is very clear about this, as is our organization. We will tell you there is not one single appliance that's effective on all patients. I want you to be very aware of the different appliances out there. I use 6 or 7 different kinds in my office. I don't have a favorite. I mean, I've got a few favorites, but it's important to know a lot about all the different appliances. So I'm hoping that you visited the booths out there and seen some of them that are here, but there are even more that aren't here. I've got patients that come to me simply because on my website I show different appliances. Patients are educated as well. They know there's not just one appliance that's going to work for everyone. There's a guy in my town in Dallas. He makes one appliance. You probably know who that is and what appliance he makes. Was there a question back here? Okay. Just stretching. Get boarded. If you had 2 options of sending a patient to a dentist, one was boarded and one was not, who would you send it to? Yeah. Of course. Yeah, you even made that comment. You said, I don't know if they're boarded or not. That was a concern. Okay, now we're making it very, I'm not going to say easy, but we're making it available to all of you that are not boarded out there. I know a lot of you are taking the test tomorrow, and I'm glad you're doing that. Start working on cases, get them sent in. Very, very important, and it's well worth the effort. Let's put it that way. It's some work, but it's well worth the effort. A friend of mine in here just emailed me a few days ago and said, I got my notice, I got boarded, and he was jumping up and down. He was in his office with his team, and they were all going crazy. You don't know how that feels until you get boarded. It's fantastic. So please, everybody, work on that. Are you boarded? Oh, okay. Pretty evenly split there. Okay, so about a third of you have no interest in getting boarded. And maybe some of you are technologists, or your team out there, maybe you have no reason to get boarded. So we'll just assume that. We assume everybody else wants to get boarded. Take Medicare. All right, we talked about this yesterday. We even brought in a Medicare speaker for you guys. I'm glad to talk to you. Anything about Medicare you want to talk about, but I think it's a very important thing to do. I know you're not going to get paid a lot of money with Medicare, but your sleep physicians will appreciate that. Remember, we're talking about how to gain favor of sleep physicians, and they want you to take Medicare. So do everything you can to start that process if you haven't started it. I guarantee you they're going to be more pleased with you taking Medicare than not.
So
Yeah.
if a physician asks you if you take Medicare, but you're not participating, you just say yes?
Oh yeah, I say yes.
You don't give them any detail?
No, there's no need to. Yeah, because you can accept assignment at any time, or you can charge more than what Medicare charges. You can make that decision on a case-by-case basis. Yeah. All right. You know, if I had asked this question 3 years ago, the number taking Medicare would have been about 5%. I would venture to say most of you have gotten credentialed or become a DME provider in the last few years. That's amazing, and that's great. I'm glad half of you are Medicare providers. We have an aging population. 15% of the US population already is in Medicare. That's going to move to 79 million. It's going to almost double by 2030. People are living longer. And 50% of Medicare patients have sleep apnea. So if for no other reason, you need to be treating these patients because they're sick and they need us. All right? Maybe they're not going to pay you that much money, but they need us. Minimize cost for the patients. I've already said this, and I need to repeat this. Let me tell you a quick story. I was at the AAS, some of you might have heard me tell this story, but I was at the APSS meeting a few years ago, maybe 5 years ago by now, and I decided I would do a little research project, and I would poll 10 sleep physicians. I would make sure that they were on board with providing oral appliance therapy first. That was what I had to make sure of before I asked them these two questions. So I asked them that, and then I said, okay, here's a scenario. You move into a new town. There are 2 dentists in your town. One of them is boarded. They've been treating for 25 years. They're not part of any network. Okay, so your patients are going to have to pay a little more. Second dentist just started treating 3 months ago, went to a weekend class, but he's already on plans, and it minimizes the cost for your patient. Which of these 2 dentists do you send your patient to? What do you think happened? 10 out of 10 said they send it to the guy that's going to be cheaper. Could not believe it. And it was a private one-on-one conversation, right? This wasn't in a group. In a group, they'll say, oh, I'm going to send to the boarded doctor. Keep costs down. Personal letter of thanks. This is something that we've been doing for quite a while. If you have patients that are successful with therapy, they come back in. How many of you have some happy patients? Yeah, okay. They're sleeping with their partner again. They're not fatigued. They're not falling asleep at stoplights. They come in, if you have a card, and if the physician referred the patient to you, say, you know what, why don't you just send a letter of thanks? We've got a card right here. Send a letter of thanks and we'll mail it for you, thanking the physician for referring you to me. Easy to do. And do you think that sleep physician gets thank you cards from anybody else? No. No. Just a strategy to use. Offer combination therapy. We've talked about that a little bit this weekend already. Combination therapy is what some sleep physicians are looking for because they have patients that are upset with the pressures. So just find ways to provide combination therapy. Okay, so let's review. You want referrals, you've got to prove efficacy. Just don't tell your sleep physicians you provide HSIT. Offer literature, correspond regularly. I can't emphasize that enough. Continue to correspond. I probably send 15 letters a day to sleep physicians just about how I've worked with their patients. Correspond, correspond, correspond. Upskill yourself. Go to more education. Offer a variety of appliances. Take Medicare. Get board certified and minimize the cost for your patients. Thank you very much. I appreciate your attention. I'm out of time, but I'm here all day. You can certainly ask me questions. I think we need to wrap this up and get our next speaker up here. You've got a treat. Paul Van Willingham is going to be coming up here and talking to you about credentialing. So if you need to get up and stretch, go get a drink of water, whatever, just be back in your seats very quickly. We're going to get Paul up here as soon as we can.